Okay, so what I'm going to talk about is about how the learning that we've established in the Rebuild program over the last 3 years is relevant to the questions that are arising in relation to the Ebola outbreak. And the presentation is in comparison of what happened in northern Uganda in 2000 to 2001 and what happened in Sierra Leone in 2013 to 14, with some thoughts about why such different outcomes applied. We also have a briefing on this, which everyone's welcome to pick up from the table, and which Nick is very happy to send to anybody in East Kilbride who would like it. Okay, so the first point that I want to make is that Ebola seems to be a particular risk in conflict-affected settings. And our 2 case studies are examples of those kinds of settings. And it suggests that the interrelated effects of civil wars and other kinds of wars are somehow involved in increasing risks of outbreaks like Ebola. So clearly the 3 countries that are involved in the current or recent outbreak are conflict affected. Perhaps Guinea's conflict is less well known, but the Liberia and Sierra Leone conflicts had knock-on effects for Guinea's large numbers of refugees from Liberia and Sierra Leone in the part of Guinea in which Ebola emerged. So there does seem to be a connection there. Other outbreaks, like in northern Uganda and in the Democratic Republic of Congo, have predominantly occurred in conflict-affected settings. There was also a more recent outbreak in Uganda, and more in the stable part of Uganda, so it's not uniquely the case, but there does seem to be a connection with conflict disruption and the emergence of Ebola. What are the reasons for that? One seems likely to be population displacement, which has generalized risks for infectious disease, whether it's new emerging diseases or well understood diseases and well established diseases. Other reasons are that there's livelihood disruption that goes on around conflict. So if people are short of food and water, they're forced to more marginalized subsistence, which might include using bushmeat as a means of sustenance, where people don't normally do that. And it also may involve short-term exposure to forest-based subsistence. So, for example, as active combatants are advancing, retreating, reconnaissing, they're hanging out in forests, sleeping in forests, potentially, again, using bushmeat or getting bitten by forest-based animals. Similarly, refugees fleeing war zones. These seem logical explanations of why Ebola may emerge in these places. And we'll talk a bit more about the Guinea and northern Uganda stories shortly. Clearly, I think it's well understood that the failure to manage the initial emergence of Ebola in the recent outbreak was premised on the ineffective operation of health systems. It's not a novel point. Some of the things that are obviously needed in order to respond actively to Ebola as threat detection, contact tracing, timely response to patients, and so on. But there are also specific complexities of the conflict-affected health systems that go further than that. And so one of the things that I want to ask in this presentation, what are those specific complexities of conflict-affected health systems and how they might have affected that? But before we can do that, we first have to say, well, which health systems are conflict-affected? Sometimes I think we think it's kind of self-evident what's conflict-affected and what's not, but we've found as we've embarked on talking about this, that it's actually not as simple as all that to decide what you're talking about when you mean conflict affected. There are some definitions around, and clearly the fragile state is well defined, and that version of that definition there is DFID, so you're probably very familiar with it. But if you don't mind me saying so, it's really imprecise. It's inclusive of highly heterogeneous state characteristics, and we haven't found it terribly useful as a guidance as which ones are and which ones aren't. So we start by thinking, is conflict affected a more specific term? But actually, we're all conflict affected, aren't we? I mean, if you think about global conflict, we're all affected by it. We're all affected by the security precautions that we have to take as we enter the DFID building. You know, we're conflict affected. We've all had a conflict more locally at some point. So, you know, we had the Second World War is not so very long ago, and we were bombed. And you know, when does it run out? Being conflict affected. So there are time-related questions. And then what is conflict? Is it, you know, if we have an argument in the corridor, is that conflict? Clearly it's something, you know, more than that. But, you know, again, defining it isn't obvious. And, you know, in one of our case study countries in Rebuild, Zimbabwe, you know, there's a real question, was what Zimbabwe's recently gone through conflict, or was it not conflict? It all depends how you define it. So conflict affected may not be that much easier to define than fragile. But we found this schema from the Centre for Peace and Development, I think it is, quite useful. And it's over 2 slides. And it goes from the immediate sorts of things that might happen at the end of a conflict, like cessation of hostilities and violence, signing of peace agreements, demobilization, disarmament, reintegration, refugee repatriation, and they offer a series of indicators to suggest whether these things are happening or not, carrying on to establishing a functioning state, reconciliation and integration, and economic recovery. And I think where we're at is saying that all the intermediate rows of this table, everything from you know, signing of peace agreements through to reconciliation and integration, constitutes post-conflict. The cessation of hostilities and violence is still the conflict, and the economic recovery, is the end of the post-conflict period. So that's where we're at, and what we're trying to operationalize as our definition of what conflict affected means. So that's a bit of a digression, but I think it's also, I think, quite important to recognise that it's not as straightforward as it sounds to talk about what is post-conflict. So then there are questions about, are post-conflict health systems different? And this is a list of characteristics of post-conflict health systems that's offered by Bill Newbrander in one of his publications. And I'm not going to read out all the things on it, but I think you probably agree that those aren't terribly different from other, exactly. So you might say they're the same, but more so. Maybe it's worse in post-conflict settings than it is in other places. But so we're not very impressed by Newbrander. In other words, I'm sure those things are likely to be true, but they're likely to be true of many places. Our colleagues at Makerere came up with this set of characteristics that I think are much closer to starting to talk about what's peculiar about post-conflict settings. It's about disruption, it's about loss of infrastructure, flight of health professionals, interruption of drug supply. We think that, and we'll be coming back to the point about coordination, regulation and trust as being really important issues, and I think really important issues in relation to Ebola and displaced communities, which I've already talked about in relation to why Ebola might have emerged in the first place, but you know, also affects the functioning of the health system. So in terms of what some of the direct effects of conflict are, just to slightly stand back from that list of things, health workers desert conflict zones. They're often at increased risk even compared to the general population because they're prized assets by armies. Obviously they need health workers. So some of our case studies talked about health workers disguising themselves as ordinary people, avoiding, you know, we might expect ambulances to be respected as, you know, not part of the conflict, but actually often they're targeted. So health workers often have to conceal themselves during the conflict rather than use it as something that might make them safer. Damage to infrastructure and loss of records often also obviously happens when there's warfare that may result in the bombing of health facilities or the burning down of facilities. Although shortages are a general characteristic of many low and middle income countries, the skewedness of them can reflect the patterns of the conflict. And that's both a skew in relation to regional conflict patterns, but also you can get a whole generation missing of health workers where there hasn't been any recruitment and training of health workers over a period. So sometimes you've got this big gap in the health system between, you know, older, more senior health workers and junior, very, very inexperienced health workers, and nobody in the middle, which causes certain kinds of difficulties. And you also just lose senior staff altogether, and they're often the more able to avoid the worst parts of the conflict, and that results in inexperienced staff in senior positions. So those are all direct effects of the conflict, but there are also a series of consequences of the global response to the aftermath of the conflict that make health systems a bit different. So there can be, not always, but at least I would say in 3 of the countries that are rebuild case studies, a sort of inundation of aid from multiple partners. And the management of that has been one of the major factors that has generally been recognized in the literature about differences between conflict-affected health systems and others. And I think that's partly because a lot of that literature comes from people operating in humanitarian space in the immediate aftermath of conflict, where that's obviously a very important issue. But in the longer run, the issue that really emerges as important is that you have very inexperienced officials, because the most senior people probably left, trying to deal with very senior, articulate, often a bit pushy international aid-related actors. And what happens as a result of that is that local voices and understanding of local context gets marginalized in the debate about reforms and health system strategy. So we'll come back to some of those points, but I'm now just going to sort of quickly go over, some of the things that we know happen, partly from rebuild research, partly from the literature, in the 2 Ebola outbreaks that are the case studies. So in northern Uganda, 2000 to 2001, it emerged in Gulu district in the center of the conflict in October 2000. 2 clusters were first noticed, one in a funeral party. I can't remember where the other one was, but the index case was never identified, which speaks a bit, I think, to the levels of chaos around, that they weren't able to trace back to the index case, even in the way that they largely have in Guinea. It's thought likely to have been associated with movement of people and armies, so the case of the more transient exposure to forest-based subsistence, probably. The numbers involved were 425 were infected, 224 died. That's a case fatality rate of 53%, and 17 of the dead were health workers. So that obviously pales in comparison to the more recent outbreak, but at the time it was the biggest outbreak there had been. What did the response look like? A national task force was established 4 days after the notification of the epidemic, or the outbreak rather. A set of response strategies was put in place, standard things, contact tracing, public education, community mobilization, isolation of cases, infection control, safe burial, and so on. CDC established an on-site laboratory, which may be an important point. And I think probably the most important point is that this national task force seems to have done a very effective job of coordinating the national strategy and coordinating all the international actors within the national strategy. And following the establishment of the national task force, a district task force was established in Gulu, and as the outbreak spread to other districts, other district task forces were established as well. So here are perhaps some of the reasons why they were successful in controlling the outbreak quite quickly: prompt action and effective coordination. Some anthropologists have suggested that the ways that the Acholi people manage infectious disease in their communities was conducive to preventing spread. And if anybody's interested in that, I'll tell you a bit more about that, but it's quite interesting. That there was effective public communication, effective surveillance mechanisms, trained burial teams. Some people have suggested that the prior experience of the AIDS epidemic was important. As we know, Uganda was seen as having had a very successful effort at controlling AIDS, and that may have built, for example, trust between public health functions and communities, that they could trust the messages coming from them. And obviously it meant that there was a strong public health function that had been developed around AIDS. And also suggested to be important is that there was a large and effective NGO hospital in the middle of the epidemic, that certainly when UN officials first arrived in the outbreak area, they were remarking on how good the facilities were relative to what they'd seen in other outbreaks, and that may well have been important. That's not to say that there weren't any problems in the Ugandan response. The conflict was actually ongoing rather than a post-conflict scenario at the time, and there were, for example, problems of public health teams being fired at by rebel armies, although there was also examples of cooperation from rebel armies as well. So it was a mix, but certainly they needed to go in convoys to their control efforts and to have army accompaniment to protect them from risks. They didn't have enough supplies for barrier nursing at first, and there hadn't been enough prior training on barrier nursing methods. And that's implicated in 14 of the 22 health workers who established the first isolation wards becoming infected. They didn't do anything to particularly reward or motivate health workers to step up to these considerable additional risks and workload, but they did eventually. And there were issues of stigma and mistrust of what was going on in the burial processes. It wasn't that those things weren't there at all. Specifically, our health worker life histories that we've conducted in Uganda, we sort of had another look at them with a view to trying to specifically looking at what they said about that outbreak. Obviously, they weren't collected with that purpose in mind, but they talked about the increased workloads during the Ebola outbreak, on top of all the challenges they're already facing in the conflict. I mean, when you think about it, these poor folks, they're targeted as part of the conflict, and then Ebola arrives, and many of them die, and there is a point at which they are on the verge of refusing to support the Ebola epidemic, and then the very charismatic doctor that we all know about, Matthew Lukwiri. You can teach me how to say that properly later, Freddie. He was very instrumental in encouraging health workers to keep their efforts going. So it wasn't only his individual heroism, but he was also very influential over other health workers. The health workers talk about their strong pride in their health worker role, and how that kept them going through those difficult conditions. They talk about task shifting and extending their job descriptions to cope with what needs to be doing. And they also talk about when the additional payments did arrive, how that was motivating, and felt that they were being recognised for the work they were doing. So turning to Sierra Leone, the early delays in managing the outbreak obviously occurred in Guinea, and our focus is on Sierra Leone. So we're not so focused on why wasn't the outbreak initially controlled. But the number of cases in Sierra Leone rose sharply in May, and there was a very slow response to recognising that this was something that was important and needed a coordinated and major effort. So all the basic measures that we talked about in Uganda being put in place very quickly, under the guidance of the National Task Force, were sort of very slow to be established in Sierra Leone. And among the reasons for that were shortages of staff, which are really extreme in Sierra Leone. I mean, we did a comparison of Sierra Leone human resource distribution issues in the very early stages of rebuild, and it's really one of the most extreme pictures of hardly a qualified health worker outside the capital city at all. So we talk about maldistribution, but there really is, there's maldistribution, and then there's Sierra Leone really. There was very little personal protective equipment, and there was limited laboratory capacities, and no CDC coming in and establishing a local laboratory. So confirming cases was difficult, even once other things were there. What's pretty well documented is really big problems of lack of trust and lack of cooperation between the population and the government control efforts. And I think that that's likely to be in part a legacy of conflict, in part a legacy of the things that caused the conflict in the first place, about weak, poor relationships between the state and the people, and the lack of impartiality perceived as a sort of broker of ethnic and internal regional rivalries. That there's a long history of that, and although the current Sierra Leonean government may be seen to be a significant improvement on previous ones, these issues don't go away overnight. And then there are a number of factors that aren't conflict related. It would obviously be overstating the case to say everything about it was all about conflict. And I think probably most of these points are well understood, but coming in the middle of 3 international borders makes for specific complexities. You've also got France dominating in Guinea, Britain dominating in Sierra Leone, and America dominating in Liberia. So it's not even as if it was a border with the same aid agencies, or even ones that talk to each other particularly well. Clearly there were major issues of the international support that I'll come back to. WHO's catastrophic failure, according to their own leaked report, and maybe something about complacency, about the relative ease of control of new diseases, something either about, or perhaps both about, learning from the Uganda epidemic. Oh well, we might lose a few hundred, but we'll get there in the end, and lack of recognition of why it was only a few hundred. And also probably a reaction to some of the swine flu criticism that WHO got about having overreacted, and what you might have seen as a huge success. The world did not succumb to a swine flu pandemic. Our research shows that although there had been certain elements of health system strengthening around the Free Healthcare Initiative in Sierra Leone, they were quite marginal. And when you consider the very poor state of the Sierra Leone health system, marginal changes were simply not sufficient to deal with this kind of shock. So these problems of chronic understaffing, demotivated, overworked health workers, despite some marginal improvements, were still really dominant characteristics of the health system. And this problem of lack of trust between service users and providers had really not had time to start to diminish. If we compare northern Uganda and Sierra Leone, I think there are a number of key issues. The Ugandan state wasn't wholly conflict affected, so it did have a stable state that could be relied on to immediately set up the National Task Force, and that is strong and not especially fragile. The Sierra Leone conflict had paralysed the economy, paralysed provision of public services, and destroyed government institutions, and the aftermath of that was still very present. And the public health system, really, when you consider that certainly the health workforce distribution was almost non-existent in Sierra Leone compared to northern Uganda. I think there's a high level of reliance on informal systems in both countries, but in Sierra Leone probably even more so relative to northern Uganda. One issue might well be the lack of decentralised authority and capacity in Sierra Leone. It wouldn't have been feasible to set up a district task force, and definitely sort of slow information coming from the centre. Miscommunication between centre and DHMTs seems to have been part of the issues. There was no equivalent of the St Mary Lacour Hospital at the centre of the outbreak. The central hospital was the Connaught public hospital, with all the problems of public hospitals to deal with. And then maybe part of it is just the timing. These global public health politics that we're talking about around swine flu and general problems in WHO probably involved in why WHO in particular was less reactive than it had been in Uganda. And I'm saying this trust word again, it does seem to just come up right across the piece. So finally then, conclusions, conflict and its aftermath increases the chances of Ebola outbreak and reduces the ability to control it. And problems are worsened if the international support is fragmented and poorly coordinated, or if it's directed by people who don't really understand the local context. And I think there's a number of things about the way that problems emerged around burial practices and so on that specifically relate to a lack of understanding of how to do things differently, given some of Sierra Leone's specific characteristics. And probably the more stable governance situation in Uganda is probably one of the factors supporting greater success. So, thank you.